blood pressure. Causes of intraoperative hypotension or shock. Shock condition characterized by inability of cardiovascular system to maintain adequate and organ perfusion and delivery of oxygen to the tissues. Hypovolemic or hemorrhagic shock, most common form of shock due to decrease in intravascular volume. Obstructive shock, obstruction of blood into or out of the heart. Increased GVP, distended neck veins, increased systemic vascular resistance, insufficient cardiac output CO. Example, tension pneumothorax, cardiac tamponade, pulmonary embolism, and other emboli, fat air. C. Cardiogenic shock, increased GVP, distended neck veins, increased SVR, decreased CO, myocardial dysfunction, dysrhythmias, ischemic infarct, cardiomyopathy, acute valvular dysfunction, septic shock, spinal neurogenic shock, decreased sympathetic tone, hypotension without tachycardia, or peripheral vasoconstriction, warm skin, anaphylactic shock, drugs, vasodilator, high spinal anesthetic interfering with sympathetic outflow, other transfusion reaction, Addisonian crisis, thyrotoxicosis, hypothyroid, Arthro-Carbo syndrome, intraoperative shock, shock TED, S. Sepsis or spinal shock, H. Hypovolemic or hemorrhagic shock, O. Obstructive shock, C. Cardiogenic shock, anaphylactic shock, transfusions, E. Endocrine addiction disease or hyperthyroidism, drugs. Blood pressure equal to cardiac output multiplied by SVR, where cardiac output equal to SV multiplied by heart rate. SV is a function of preload, afterload, and contractility. Causes of intraoperative hypertension. Inadequate anesthesia causing pain and anxiety. Pre-existing hypertension. Coarctation and preeclampsia. Hypoxemia, hypercapnia, hypervolemia, increased intracranial pressure, full bladder, drugs, epinephrine, ephedrine, cocaine, phenylephrine, ketamine, and withdrawal. Allergic or anaphylactic reaction, hypermetabolic states, malignant hyperthermia, neuroleptic malignant syndrome, serotonin syndrome, thyroid storm, pheochromocytoma. Fluid balance and resuscitation. Total requirement maintenance blood deficit and ongoing blood loss. In surgical setting, This formula must take into account multiple factors, including pre-operative fasting, decreased fluid intake, increased losses during and before surgery, fluids given with blood products and medications, increasingly enhanced recovery after surgery protocols recommend consumption of clear fluids up to 2 hours prior to surgery. Both inadequate fluid resuscitation and excessive fluid administration increase morbidity postoperatively. What is the main maintenance? Average healthy adult requires approximately 2,500 milliliter water every day, 200 milliliter per day via GI losses, 800 milliliter per day insensible losses, for example, respiration, perspiration, and 1,500 milliliter per day via urine loss. Beware of renal failure. Replacement of third space losses is not warranted. Maintenance should not exceed 3 milliliter per kilogram per hour. Increased requirements with fever, sweating, GI losses, vomiting, diarrhea, NG suction, adrenal insufficiency, hyperventilation, and polyuric renal disease. Decrease the requirements with anuria, oliguria, SIADH, highly humidified atmospheres, and CHF. Maintenance electrolytes, sodium 3 milli equivalent per kilogram per day and potassium 1 mg per kilogram per day. 4-to-1 rule: 4 milliliter per hour first 10 kilogram, then 2 milliliter per hour next 10 kilogram, and 1 milliliter per hour for every kilogram after to calculate maintenance fluid requirement. May also add 40 kg to weight for adults to calculate maintenance fluid requirement in milliliter per hour. 50 kg patient maintenance requirements as follow: fluid 40 plus 20 plus 30 equal 90 milliliter per hour. Sodium 150 mg per day. Potassium 50 mg per day. Above patients' requirements roughly met with 2/3 dextro 5W and 1/3 normal saline. 2/3 plus 1/3 at 100 milliliter per hour with 20 mg kCl per liter. What is the deficit? Patients should be adequately hydrated prior to anesthesia. Total body water 60% or 50% of total body weight for an adult male or female, respectively. For a 70 kg adult male, total body water is 7 multiplied by 17 multiplied by 0.46 is 42 liters. Normal sodium content determines ECF volume. Sodium determines ICF volumes. Hypovolemia due to volume contraction, extrarenal sodium loss, GI vomiting, NG suction drainage, fistula, diarrhea, skin respiratory insensible losses, fever, sweating, burns, vascular hemorrhage, renal sodium and water loss, diuretics, osmotics, diuresis, hypoaldosteronism, salt wasting, neuropathies, renal water loss, diabetes insipidus, central or nephrogenic, hypovolemia with normal or expanded ECF volume, decreased CO redistribution, hypoalbuminemia, cirrhosis, nephrotic syndrome, capillary leakage, acute pancreatitis, rhabdomyolysis, ischemic bowel sepsis, anaphylaxis, replace water and electrolytes as determined by patient's needs. With chronic hyponatremia, correction must be done gradually over 48 hours to avoid central protein myelinosis. Total body weight, total body water 42 liter, two-thirds ICF 28 liter, and ECF is 14 liter, and three-quarter is interstitial 10.5 liter, and one-quarter is intravascular 3.5 liter. This is the Starling's forces maintain balance. Total body water division in 70 kilogram adult. Signs and symptoms of dehydration. Percentages of body water loss 3%. Severity mild. Signs and symptoms decreased skin turgor, sunken eyes, dry mucous membrane, dry tongue, reduced sweating. 6% moderate. Oliguria, orthostatic hypotension, tachycardia, low volume pulse, cool extremities, reduced filling of peripheral veins and CVP, hemoconcentration, apathy. 9% severe, profound oliguria, and nuria, and compromise the CNS function with or without altered sensorium. What are the ongoing losses? Traditionally thought that fluid loss during surgery resulted from blood loss from Foley catheter, entry, surgical drains, and third spacing, sequestration of fluid into other body compartments such as GI, lung, evaporation. Fluid therapy accounting for these losses often resulted in excess crystalloid administration, goal-directed fluid regimens associated with lower rate of post-operative complications compared to predetermined calculations. These can be done using point-of-care ultrasound, POCUS, esophageal Doppler, pulse pressure variation available either using arterial line monitoring or certain pulse oximetry. So next section we will cover IV fluid. Uh, Thank you and see you again